Dr. Periyaswamy to offer the welcome address.
Thank you, sir. Good evening and welcome you all for this 39th IACA webinar of Pudukkottai Society of Anesthesiologists. On behalf of IACA Pudukkottai, I welcome you all for this online webinar program. I welcome you all for this online webinar program, Pudukkottai Budan. First, I would like to thank our academic chairman, Dr. A.L.M. Meenachundaram sir, for his untired, enthusiastic and educating work of this IAC Pudukkottai branch. We achieved this because of his tireless work only. Once again, I thank our academic chairman for his effort. And today, I welcome our President, Dr. Suresh Kumar sir, President Dr. David, and members of IACA Pudukkottai, and members those who are attending this online webinar program, 13th online webinar program, Pudukkottai Budan. Today we are having three important topics. One is anesthesia for endovascular procedure, and another one is hemodynamic monitoring. Third one is intra-aortic balloon pump. For this, I welcome our chairperson, Dr. Sunil P.R., Professor, Department of Anesthesia, Sri Chitrai Tirunal Institute of Medical Science, Trivandrum. I welcome you, sir.
Thank you, sir.
And we are having three topics. First one is Dr. Parimala Prasanna Simha, Madam Professor Anesthesiology, Sri Jayadev Institute of Cardiovascular Science and Research, Bangalore. Madam is going to talk about anesthesia for endovascular procedure. Welcome you, madam. And next topic, Dr. Shubhendra Sarkar, Head Cardiac Anesthesia, Decision Hospital and Heart Institute, Kolkata. So is going to talk about hemodynamic monitoring, part 1. Welcome you, sir. And third topic is intra-aortic balloon pump. For that, I welcome Dr. Rohini Mayur Balaji, madam from our own Pudukkottai branch. Is working as a consultant cardiac anesthesiologist, Apollo Hospital, Trichy. Welcome you, madam, on behalf of IACA Pudukkottai. And as you all know, our this online program is accredited by Tamil Nadu Medical Council, and they are giving credit hours for the delegates, those who are attending this program. 0.5 credit hours for the participants and 1.5 hours for the speakers. For that, I ought to 100 to be paid to our online bank account. The details are given here. Again, I will post in the chat box. And we need your attendance certificate. Evidence for the attendance. Your screenshot of this participation. And another one is 100 rupees to our mail account, and your mail ID and contact number. Those particulars are to send for this mail ID address, that is IACA@yahoo.com for credit hours. These details only for credit hours. And today we are going to talk about the aorta related subject. Small poem about that aorta. Aorta, the red river with the rapid blood flow, pulsatile waves feel as pulses at periphery. Branches out to feed every organ from aorta, branches out to feed every organ. Peak pressure filters blood pressure. Systolic and systole and diastole are the synchronized each other to save our life. Arch curve to augment supply to brain and always guard our life as soul. Aorta, the Ganges from the Mount Heart. Aorta, the Ganges from Mount Heart. Aorta, the king of vascular system. With this, I once again welcome you for this online webinar program, ISA Pudukkottai Budan. And thank over to the Academic Chairman, Dr. Yala Meena Chandram, sir. Thank you, sir.
Thank you, Dr. Periswamy. So, just like that, Pudukkottai ISA has conducted 38 webinars, and we are entering into 39th webinar. It is because of the faculty support across the country. All the states in this country participated in this event, and they have given a good credit for ISA Pudukkottai, which is only 2.5 years old. It has done so much in the academic arena. Even at the time of birth, it has conducted a ISA sponsored anesthesia CME, and it has conducted cadaveric nerve block workshop. These are all the great things ISA Pudukkottai has done. And the best venture is a continuous weekly webinar with 3 faculty and 1 chairperson. And if it is 39 means, see, we have nearly covered 156 faculty in this. And the interesting point is we want to encourage the youngsters. So every time we wish to push a postgraduate as a upcoming faculty. So this is a time where the postgraduate is not there, but the erstwhile postgraduate, Dr. Rohini Mayur Balaji is there. Because when we contacted Jayadeva Institute of Cardiology, they still, Madam feels Dr. Rohini is a PG, and they said Dr. Rohini is from Apollo Hospital, Trichy, and she is willing to talk on IABP. So IABP is a good topic, and we are very happy that a youngster is there to present that topic. And incidentally, she is from Pudukkottai. Her father-in-law is Pudukkottai. He is by name Dr. Ramraj, and her spouse is a surgeon, Dr. Anup Srinivas. And Madam is working as a cardiac anesthesiologist in Apollo. So the best part is she is a member of Indian Association of Cardiothoracic Anesthesia, but she is not a member of ISA. So I request Dr. Periswamy to make her as a member in ISA Pudukkottai, because straight away she has joined a super specialty forum, omitting the parent body. So we request the madam also to join today after this lecture is over. It is up to Dr. Periswamy to increase the strength of ISA Pudukkottai. So that is our plus point. Madam is a DM cardiac output from Dr. Jayadeva Institute of Cardiology, Bangalore. And she is attached to Pudukkottai, and she is from Tamil Nadu. And the second is her teacher, Dr. Parimala Prasanna Simha is her teacher. She is a professor in Jayadeva Institute of Cardiology. Madam is a teacher for DM cardiac anesthesia postgraduates from 2010. She is an examiner for the DM cardiac anesthesia students. And naturally, she and her student, Dr. Rohini, they are interested in transesophageal echocardiography, like any other cardiac anesthesiologist. They are having a passion towards TEE. Both Madam, student, Dr. Subhendu and Dr. Sunil, everyone is interested in transesophageal echocardiography. And luckily, we have seen that machine a week back. So out of this much of experience in the field of anesthesiology, I have seen TEE only a week back in a corporate hospital in Madurai, because we wanted to buy it for a government hospital. So we made an attempt. But these people, all these core faculty, they're playing it, they're playing with it like computer mouse. These people are doing. So we are having great faculty. And Madam from Jayadeva Institute, Bangalore, Karnataka, Madam is here. And Dr. Subhendu Sarkar is a good friend of mine. He will not project him as a cardiac anesthesiologist, but he is working day in and out there. But he is a very easygoing guy. Usually, cardiac anesthesiologist will post a figure and they will not mingle with others. But the difference will be this Subhendu and Sunil. They will be always Sunil will be always smiling, and Subandhu will crack jokes about others. So he's a very easygoing guy, and I'm very happy that he came to Tamil Nadu and we went to Sri Rangam to worship Sri Ranganathan. At that time only, I had a close association with him. He is just like a kid. He is always kiddish. And even I asked him, Subandhu, what I want to say about you in the introduction. And he simply replied, say I am Dr. Subandhu Sarkar. So this is just like a Maya Jal, PC Sarkar, the great magician. We know only PC Sarkar magician. But after the Subandhu Sarkar came, whenever it is Sarkar, we name him only. He is interested in, again, this echocardiography. He is an international speaker in cardiac anesthesia. And again, as we are not aware of anything in cardiac anesthesia except the spelling, we wanted a top person to be the chairperson because we don't know what you are going to talk. So even IABP, I was thinking, what is the expansion for that IABP? So our level is only that much. So we catch hold of Dr. Sunil. He is also attached to a dedicated institute of cardiac and thoracic surgery, Sri Chitra Tirunal. So in India, they have made wonders, Chitra Tirunal, and he is one of the 6 professors of cardiac anesthesia there. And see, he is a timely man. He is used to routine this Zoom. Always he will be zoomed throughout the country because so many areas, even during Corona period, the only anesthetist who is known across the country is Dr. Sunil. Because for Indian College of Anesthesiology, he was conducting a continuous webinar. So another one is also from Kerala, Dr. Vijis. So these 2 people always, Dr. Sunil will be seen, and Sunil is interested in conducting quiz for postgraduates. Both of them, they will conduct ABG quiz, this echo quiz, so many things. Though these people are dedicated, and I came to know about them because even at times they will invite speakers like me because they will select only hardcore speakers, intelligent speakers. Sometimes to fill up the gap, we will be invited. At that time only, I came across these cardiac anesthesia giants, and we are very happy that SAR is also today. And today the webinar is so peculiar. One speaker is from Tamil Nadu, one speaker is from Karnataka, another speaker is from West Bengal, and the chairperson is from Kerala. So this is a best thing. So that speaks volumes about the ISA Pudukkottai Budan. And with this introduction, now I hand over the session to Dr. Sunil PR, Professor Cardiothoracic Anesthesia, Sri Chitra Tirunal, to conduct the session.
Thank you, sir. Thank you for the kind words. I barely recognize myself in that description, but I accept it all the same. So we'll enter the scientific program for today. The first talk is on intra-aortic balloon, and the talk will be delivered by Dr. Rohini Mayur Balaji. She is a consultant cardiac anesthesiologist from Apollo Hospitals, Trichy. Over to you, madam.
Thank you, sir.
Yeah.
I hope my presentation is visible to all and I'm audible to all.
Yeah, your slides, yeah, they are on full screen.
Okay.
Yeah. Okay.
Okay. I thank all my seniors, the ISA Pudukkottai branch, Parimala ma'am, for giving me this opportunity to talk. Without wasting much time, I'll just start off right away because there's a lot for me to cover, and 10 minutes, slightly a little cramped up time for IABP. So what is IABP? Simply intra-aortic balloon pump. I'll make it very simple so that it is easy for us to understand and process this information. As soon as somebody says IABP, it sounds very fancy, very big. But when I learn any topic, I address it in the terms of questions like why, what, when, how. So that is how I will deliver my lecture today in the form of question and answers. So what exactly is IABP? Straight away, what is IABP? It is nothing but a balloon that is placed into the aorta that repeatedly inflates and deflates. So that is all that there is to it. It just there's a balloon there repeatedly inflates and deflates. So what are the components of an IABP? Here, if you can see, there's this one end that is the proximal end, that is the balloon which sits inside the aorta of the patient. The other end is what is connected to the console. So, and there is a wire in between these two. So there is helium gas that is filled into this balloon, which enables us to repeatedly inflate and deflate the balloon. The other end has a Y connection. So that is in the form of one connection going to a helium source. The other one is in the form of an arterial line that is connected to the console. So we'll just have a look at the console. So this is how the IABP console looks like. So there is a monitor and a keypad, much like a laptop, with a screen and different waveforms displayed on it. And attached to it is a helium cylinder, which is the source of gas for our balloon to function. So when we open the IABP set, the sterile set, this is how it looks like. So if you can see, there are multiple tubings, which is for helium connection to the balloon. There is the balloon itself. There are multiple sheets and dilators, and there is a needle for us to access the femoral artery. It's very much similar like accessing a femoral arterial cannulation. Femoral arterial cannulation is done. Series of dilators passed over it, and the balloon is measured and inserted over that. The one end of the balloon sits inside the patient, the other end is connected to the console. So how does the IABP function? How does it benefit our patients? Basically, the principle of IABP is known as counterpulsation. Counterpulsation means the balloon inflates during the diastole and it deflates during systole. And this happens cyclically, repeatedly over a period of time. So how does this repeated inflation and deflation benefit the patient? So when does the balloon inflate? First of all, the balloon inflates when the aortic valve closes. As soon as the aortic valve closes, the balloon inflates. So what happens at this time? There is blood that is trapped inside the aortic arch. So this creates an increased pressure inside the aortic arch. And we all know that the coronaries arise from the aortic arch. So when there is increased blood, when there is increased pressure inside the arch, the coronary perfusion is improved. So in other words, all of this translates into an increased myocardial oxygen supply. So everything that we deal with IABP boils down to two things. One is myocardial oxygen demand, the other is myocardial oxygen supply. So with inflating the balloon, we increase the myocardial oxygen supply. So what happens when the balloon deflates? So when does the balloon deflate? It deflates just before the LV starts to contract. So when the balloon deflates, what happens? There is a suction effect. There is a sudden drop in pressure. There's a vacuum that is created, and there is a suction effect that is created at the arch of aorta. So when there is drop in pressure, what happens? There is reduction in the afterload to the LV. Afterload is nothing but the pressure against which the LV has to pump. So when the balloon deflates, there is a decrease in afterload. That means to say LV can pump better, LV can function better. So when this happens, when the afterload decreases, the myocardial oxygen demand decreases, and hence the cardiac output increases. So basically everything revolves around this concept. Any ischemia, infarction, any myocardial dysfunction is because of increased oxygen demand, whereas the oxygen supply is low. So what IABP does, when we insert an IABP, it reverses the ratio. It decreases the oxygen demand and it increases the oxygen supply. So that is the role of our IABP. So this graph here shows us the effect of counterpulsation on myocardial oxygen supply and demand. There is one thing here, DPTI, that is the diastolic pressure time index. That is nothing but the pressure difference between the left ventricle and the aorta. As the pressure difference between these two increases, the ventricle will be able to empty better. So the IABP increases the DPTI. The IABP increases the curve area under the curve of the DPTI and increases the oxygen supply. Whereas the TTI means the tension time index, that is the wall tension that is created in the left ventricle. So the IABP decreases the wall tension, decreases the oxygen demand that is there on the left ventricle. So apart from having a favorable effect on the myocardium, IABP also has effects on other organs in the form of better tissue perfusion. It causes a decrease in lactates, decrease in acidosis. It also improves cerebral perfusion and improves renal microcirculation too. So where exactly do we place the IABP? So if you see here in this picture, the proximal end of the balloon sits just distal to the left subclavian artery, and the distal end lies above the renal artery origin. So this is very important. The positioning is extremely important because too proximal positioning can occlude the branches that arise out of the aorta, so that we would be harming the patient. And too distal a positioning will be, the balloon will shift over and sit over renal artery. So we are compromising the perfusion. So the positioning of the IABP is extremely important. So how do we confirm this positioning? One is via transesophageal or transthoracic echocardiography. The other thing is in the form of an X-ray. X-ray, we can usually see a hyperlucent balloon tip. So that should lie just above the carina, that will coincide with the second or the third intercostal space. Or usually IABP, when it is inserted in the cath lab, so there you do a direct fluoroscopy, you can very easily see where is the balloon position, and you can also very beautifully see how the balloon inflates and deflates in real time in the cath lab. So when do we insert IABP? So basically here we are seeing what are the indications for us to insert IABP and which of our patients are the most beneficial for IABP. So any cardiogenic shock, whatever reason, ischemia, chronic congestive cardiac failure, whatever reason, for whatever reason patient is in cardiogenic shock, when there is decreased tissue perfusion, we can insert an IABP. Patients undergoing high-risk percutaneous interventions, or sometimes in setting of cardiac surgery where we are unable to wean the patients off bypass, we will support the patient's heart with IABP and enable the patient to come off bypass. Patients who have refractory ventricular arrhythmias, be it in cath lab during PCI or during grafting or any other intervention in the OT, when the patient has refractory arrhythmias not responding to any other pharmacological or defibrillation, IABP is a good option at that time. Or if there are any mechanical complications of MI in the form of ventricular septal rupture or in the form of papillary rupture leading to acute MR, these are all the situations where IABP can be used. And if we have to translate this use into numbers, this is how I would put it across. If there is sustained hypotension in the form of a low mean arterial pressure less than 60 mmHg, or low systolic blood pressure less than 90 mmHg, or a low cardiac index lower than 2 liters per meter square, or rising PCWP, or rising right atrial pressures more than 20 mmHg, or increasing SVR. As I already told, IABP's main role is in the form of decreasing the afterload. So anything with an increased SVR, any patients with increased SVR more than 2000 times, in those patients also IABP will be very, very useful. And also if there is any, all these indicators of low cardiac perfusion, low cardiac output in the form of oliguria, low mixed venous saturation, or rising lactates, all of this which indicate myocardial dysfunction, these patients also will benefit from IABP. So there are certain contraindications for IABP. There are absolute and relative contraindications. Absolute being very severe aortic regurgitation, dissections or aneurysms of aorta. Relative contraindications will be in the form of uncontrolled bleeding problems for the patient, any bleeding disorders, or severe peripheral artery disease. Peripheral artery disease, again, if the patient is stented or has any graft, even in those cases, it would still be safer to go ahead and insert IABP. So when we are looking at a procedure, we should also know about the complications associated with this. This can be broadly classified into vascular, mechanical, and life-threatening complications. Vascular complications will be in the form of limb ischemia, bleeding, stroke, and in the form of thrombocytopenia. Mechanical complications, the balloon can rupture sometimes. So if the balloon ruptures, how we identify that is in the form of, when you look at the helium gas line, there will be blood coming out into the helium gas line. Normally helium gas line will be clear, there will be nothing seen into the inside the helium gas line. So any balloon rupture, leak, or the tip of the balloon can have a clot formation. And sometimes the balloon itself can get entrapped into the aorta, will not be able to pull the balloon out. So these are mechanical complications, and life-threatening complications in the form of dissection. So when we are inserting the IABP, when you're putting in the guide wire, there can be dissection of the aorta, there can be rupture of the aorta, or if the limb is occluded for a long time, if there is any thromboembolic phenomenon, in that time you can have a compartment syndrome developing in the limb. So this can be a life-threatening complication. So we will briefly look at what are the AHCC, HA and the European Society guidelines for using IABP. There's a slight difference between the two governing bodies. ACCHA recommends a class 2A for IABP insertion for patients who are in cardiogenic shock associated with MI, which does not stabilize with pharmacological therapy. Pharmacological therapy, we are talking about inotropes and vasoconstrictors or inodilators or whatever the pharmacological therapy. So this is a class 2A indication that is provided by ACCHA, whereas European Society has actually downgraded IABP insertion to a class 2B indication. I will discuss a few trials later on. We will see why there is this differentiation between these two. So this is basically the console. This is how the back of the console looks like. So there is a port for us to, there's a provision for us to open the helium cylinder. There is a provision to connect ECG. There is a provision to connect the helium inlet, and there is a provision to connect the arterial line. So this is just a rough guide for us to know there are different sized balloons available for different people. It's not a one size that fits all. So depending on the height of the patient, we can select whatever balloon is appropriate for the patient. Oh, this probably I'll skip these because of lack of time. This is just basically how to prepare the line, how to insert. So if there is time at the end of all the lectures, probably I'll come back to these slides and we can discuss these. So basically, how does the machine, this is after all a machine, so it cannot function on its own. We need to give it an input. So how does the machine know when to inflate the balloon and when to deflate the balloon? That is in the form of triggers. So the commonly used triggers here, if you can see on the console, or the topmost waveform that you see is the ECG. The second waveform that you see is the arterial line trace, and the third waveform that you see is the waveform of the balloon inflating and deflating. So the different types of triggers as seen in this slide. One is ECG. Very commonly used are ECG and the pressure tracing. If the patient is paced, the pacemaker spike can also be used as a trigger. There is another mode called an internal mode. Internal mode is when the patient has arrested, when there is absolutely no cardiac output. When you're giving CPR, the IABP just keeps on pulsating at a preset rate between 80 to 120. You can set the rate at whatever rate you're comfortable with. Or when the patient is on CPB, at that time also you can use an internal mode to deliver pulsation. So it can, like something like, usually on CPB, it is a non-pulsatile flow. If in case you want to maintain a pulsatile flow, you can as well use this internal mode and start pulsating the balloon when the patient is on CPB as well. So this is a little about the triggers. And if you can see this, the upper trace, the one in the red is the arterial trace. The first part of the arterial trace is the one that we are already familiar with, which we use routinely in our OTs in the form of a systolic upstroke and a diastolic notch. Whereas the second part that is starting, that is the one which is coinciding with the balloon inflation. If you can see the blue dotted lines, the balloon inflation starts off at the onset of the diastole. So at the onset of the diastole, when the balloon is inflating, it increases the pressure in the aortic arch. So this is increasing the diastolic pressure. This is called as diastolic augmentation, which improves our coronary perfusion. And after that, after the balloon inflates, it rapidly deflates. So after it rapidly deflates, there is a downstroke that is coming. That is the assisted end aortic end diastolic pressure. If you can see, there is a difference between the unassisted aortic end diastolic pressure and the assisted end diastolic pressure. Unassisted end diastolic pressure is our normal diastolic pressure. The assisted end diastolic pressure is much lesser than the normal diastolic pressure. So there is this concept, there is something known as a left ventricular end diastolic pressure. Any increase in left ventricular end diastolic pressure means there is increase in the volume, there is increase in the pressure inside the left ventricle. That means to say there is increase in tension in the left ventricular wall. So this translates to increased oxygen demand. So when IABP is used, when the balloon deflates, when the afterload decreases, the end diastolic pressure also decreases. So this translates to decreased oxygen demand for the myocardium. So this is the aortic, this is the waveform that is there when the balloon inflates and deflates. So if you see the next waveform, that is the assisted systole. The assisted systole is much lesser than the unassisted systole. So in comparison, the unassisted systole and diastole are higher than the assisted systole and the diastole. So basically, the balloon inflation is increasing the coronary perfusion pressure. It is decreasing the afterload. So hence, this is increasing the oxygenation of the myocardium. So this shows the balloon waveform. What happens? This is the balloon waveform, as in when the balloon inflates and deflates. This is the waveform that we usually see. So again, there are a lot of errors which can occur. This is basically for troubleshooting how different waveforms show and what those different waveforms indicate. Again, this will require a little detailed discussion. Probably we have time. We will come back to this slide at the end of all the lectures. So one more important thing I would like to make a note of for everybody is there are a few trials that have been done, few landmark trials that have been done with respect to IABP. First, most important one was the shock registry. This was a very early trial that came in probably in the 1990s. So they reported a better in-hospital mortality rate outcome for the patients who were treated with thrombolysis with IABP versus those treated with thrombolysis alone. So IABP definitely helped. So they said IABP was better to reduce the mortality in patients with acute MI. However, there was one more trial called the TACTICS trial, which compared a very similar population, thrombolysis and IABP versus thrombolysis alone. But this group of investigators, they did not find any overall mortality benefit with IABP at 6 months, post 6 months. IABP shock 2 trial, again a landmark trial. They compared IABP without versus no IABP in patients with cardiogenic shocks who are coming with acute MI. They studied about 300 patients in each group, and they studied 30-day mortality. In the patients who had IABP, the mortality rate was around approximately 40%, whereas the non-IABP group had a mortality rate of approximately 41%. So 40 versus 41, it was not a very significant difference. So they did not demonstrate any really overt positive effects in the form of IABP therapy. Dr. Lee et al. Performed a meta-analysis of 29 studies. They showed that almost 5,000 patients were recruited. They showed reduced in-house hospital mortality when IABP was used in conjunction with ECMO, as opposed to ECMO alone. And another trial, Impella versus IABP. Impella is a assist device, ventricular assist device. So two groups of patients, Impella versus IABP, in patients presenting with STEMI and cardiogenic shock who underwent primary PCI. Outcomes were similar. The very interesting thing was outcomes were with both Impella and IABP. See, IABP is just an assist device. It is not it cannot provide cardiac output for more than 1 liter. The maximum output it can increase is by 1 liter per minute, whereas Impella can increase the cardiac output by 3 to 3.5 liter per minute. But despite this difference in the generation of cardiac output, in the improvement of cardiac output, the results were similar. The outcomes were major adverse cardiac events were similar with Impella and IABP. The only problem with this trial was that there are hardly 48 patients who were recruited. So this was a very underpowered trial. One more trial, BCIS-1 trial. The efficacy and safety of elective IABP. IABP, most of the times if we see in clinical practice, it will be an emergency intervention. Patients coming with acute MI with cardiogenic shock, we put in IABP as an emergency measure, as a salvage measure. However, BCIS-1 trial investigators, they compared elective IABP insertion prior to high-risk elective PCI. However, these investigators, again, they did not find any major changes with respect to major adverse cardiac events at the end of 28 days. So they do not recommend routine use of IABP in patients with low EF undergoing high-risk PCI. So thank you all for your patient listening. If there are any questions, I will be happy to address this at the end of the session.
Thank you. Thank you, Dr. Rohini. We'll be taking questions towards the end. So I will call upon the next speaker, Dr. Vimala Prasanna Simha. She's professor in anesthesiology, Sri Jayadeva Institute of Cardiovascular Sciences and Research, Bangalore. She will speak on anesthesia for endovascular procedures. Over to you, Dr. Parimala.
Thank you, sir. I thank Dr. Meenakshi Sundaram for inviting me to discuss about endovascular procedures and ISA Pudukkottai branch. I'll share my screen. I hope you are able to see. Are you able to see my screen?
Yes.
Okay.
Yes, you can see.
Madam. Yes.
Yes. I have no disclosures. There are a few new words for most of us. EVAR is endovascular aneurysm repair. TEVAR is thoracic EVAR. Chimney EVAR is using a chimney-like bypass for the branch vessels. HEVAR is hybrid EVAR. Fenestrated, there is fenestrated and branch EVAR also available these days for managing thoracic aneurysms. So though we discussed about IABP just now, thoracic diseases and aortic regurgitation would be a contraindication for IABP. So we are discussing diverse topics related to aorta today, but I'll concentrate mainly on the thoracic endovascular procedures. These are indicated for aneurysms, dissections, acute aortic injuries, and other thoracic diseases. In the evaluation, most of our patients are elderly, have associated coronary artery disease, diabetes, and chronic obstructive pulmonary disease. In brief about intraoperative goals, we have to optimize end organ perfusion, facilitate neuromonitoring, and adjust hemodynamic management. There could be complications of spinal cord injury, peripheral vascular injury, contrast-induced nephropathy, and endoleaks. Post-operatively, these patients are cared in a recovery room. In Jayadeva Hospital, we are doing around 5,000 endovascular procedures and many other open vascular surgeries. So most of the endovascular procedures may be done in the regional or monitored anesthesia care, and few of these patients like aortic, ascending aortic or arch aneurysms will require hybrid or hybrid theater and general anesthesia. I'll discuss 3 cases and how we have managed these, and along with that, what problems face and how we manage, we'll discuss. One is hybrid TEVAR managed under general anesthesia. Second is a Stanford type B aortic dissection for TEVAR again under spinal anesthesia. Third was a ruptured aneurysm of arch of aorta for TEVAR under monitored anesthesia care. This patient was an elderly male, hypertensive, who had come with history of backache for 2 months. His chest X-ray showed mediastinal widening, and CT aorta showed aneurysm, which was measuring in the more than 65 millimeter in the arch. So these patients undergo hybrid procedure. Initially, surgeon will put a bypass, that is deep branching of the aortic arch vessels. So from ascending aorta, the grafts are put into each of the arch vessels. After this, the under fluoroscopic guidance, endovascular stent is positioned above the deep branched, above the insertion of these grafts. So this is a complex procedure. You can see here, initially the stent is being deployed, and after the deployment of the stent, you can see that the arch aneurysm has been excluded. So what is the indication for repair? Any aneurysm that is more than 5.4 centimeter in diameter in a healthy person without symptoms also requires correction, or if the growth of aneurysm is more than 0.5 centimeter in a period of 6 months. This is because though we define aneurysm as 1.5 times, that is anything more than 3 to 3.5 centimeter is considered as an aneurysm. The risk of rupture, spontaneous rupture, equals the surgical mortality when the size crosses 5 in the female patients and or 5.5 in male patients. So risk categorization for these patients will be based on the type of intervention. You can see that if it is open aortic repair, it is if infrarenal, the risk point is 2, and if it is suprarenal, the risk is double. So in our patient who was elderly having a more than 65 mm diameter of the aneurysm, endovascular procedure carries a high risk, whereas if it is open surgical repair, it is comparatively high risk. So we can see the difference in the perioperative morbidity and mortality based on whether TVAR or open repair. Open repair, the characteristics are elderly, having the COPD with FE even less than 50%, previous history of stroke or chronic renal failure. These are high risks, whereas for for TVAR, it is extent of aneurysm, COPD, frailty index, and need for iliac access. You can see that this is the extent of aneurysm from ascending aorta till the bifurcation. There is aneurysmal dilatation. So for TVAR, these are high risk. Benefits of TVAR are less physiological disturbance, reduced blood loss, less pain, and reduced length of ICU and hospital stay. But the disadvantage is potential conversion to GA in a patient who is deemed unfit for general anesthesia, increased long-term complications like endoleak and graft migration, and the requirement of yearly surveillance. The contraindications for endovascular repair would be known allergy to contrast, nitinol or polyester, patients having connective tissue disorders, or most of the time it is the calcification of
I think we lost collection.
the setup of
You're not audible.
TVAR is used to
Madam, your internet is unstable.
an open
I think the PPD is suffering from unstable angina.
Madam needs to be contacted to tell her.
from ionizing radiation, and if no hybrid facility wiring long monitoring cables should. Procedures are best done in centers. Can you see my slides?
Yes, yes.
Hello?
We
Yes,
can see
madam.
the slides, but the audio is suffering from disconnection, repeated disconnections.
Oh, I'm sorry. Okay, I
think
hope you are able to hear me now.
right now it looks okay. Carry on. Let's see how it goes.
Okay. So there are requirements based on the CT reports. The morphological features are having adequate length and diameter for the proximal neck and avoiding thrombus. Distal landing zone length and diameter should be checked. Caliber of the vessel, tortuosity and presence of aneurysms or thrombus in iliac arteries and excess vessels. Pre-procedure assessment may include cardiopulmonary exercise testing if it is available. The anaerobic threshold of less than 10 is indicative of higher complication rate. PI and two-mer ABG may be required if there is history or patient has COPD symptoms and there is history of long-standing tobacco use and if patient is unable to climb one flight of stairs. The preoperative medications have to be continued and beta blockers, ARBs can be continued for maintaining blood pressures. And patients having atherosclerotic and concomitant aortic atheroma or ulcers, low dose aspirin and statin are to be given. We should stop giving NSAIDs in these patients. And for remote ischemic preconditioning to people having aneurysm. On arterial line, large for IV access, central venous access in complex lengthy procedures, including cardiac output monitoring where appropriate, temperature monitoring, and urine output. There are various, we had difficulty to wean the patient from ventilator to rise, and the patient had bronch done. And other complications could be say that the risk of procedures is low. Initial screening, either resting thoracic, transthoracic echo or ECG, in addition to assessment of symptom status, is adequate in most of the patients. But coronary angiogram is indicated when the patient shows two or more segments of inducible ischemia or those who are deemed higher risk, they will need formal coronary angiography and treatment of the lesions. So in our patient, LCX, which was non-dominant, had 80% lesion, and RCA showed some calcification, but no coronary intervention was required. And to avoid perioperative myocardial infarction, we have to minimize intraoperative blood loss and prioritize early intraoperative transfusion, which will reduce infarctions. The other risk is stroke or paraplegia. So this is another patient who had undergone saccular aneurysm repair in 2015 of arch of aorta, but he came back with ascending and arch aneurysm, and CT showed that only the innominate vessel, right innominate, was patent, left common carotid and subclavian were occluded, and his limb was getting perfusion through collaterals. So these are high-risk patients for stroke. Most of the stroke is usually embolic in nature, maybe due to procedural, that is additional stent implantation, or anatomic factors like inability to revascularize left subclavian artery. I'll discuss about another case. This is Stanford type B aortic dissection. This was a 60-year-old smoker, hypertensive, who he was morbidly obese. He came with history of backache for 2 weeks and renal impairment. Creatinine was 1.8 milligrams. CT scan showed Stanford type B dissection. Under spinal anesthesia, TIVAR and right renal artery stenting was done because the right renal artery was being supplied by the false lumen, and he required inotropic support during the procedure, but fortunately his post-op recovery was uneventful. So this is the image showing stent placed in the descending thoracic aorta and left subclavian perfusion is seen, and this image shows the right renal artery stenting being done and perfusion of the right kidney. So in these patients, whether to give general anesthesia or regional anesthesia. So factors to consider are patient comorbidities, use of antiplatelet or anticoagulant drugs, duration of surgery, ability to lay flat, and patient preference. We have to remember that intraoperative heparin is not a contraindication to inserting an epidural, but consideration should be given to timing of removal postoperatively when patient is still anticoagulated. Now, Stanford type B aortic dissection requires intervention when there is refractory pain, rupture, renal failure, limb ischemia, or uncontrolled hypertension. So, discussing about renal function, patients are at high risk for kidney injury if eGFR is less than 30 ml per minute, and we are going to use IV contrast or pararenal stents. So, the goal is to stop nephrotoxic drugs, adequate hydration should be ensured, and limit contrast dose. Contrast-induced nephropathy is defined as 25% increase in serum creatinine or an absolute increase of 0.5 milligram per deciliter 2 to 7 days after administration of contrast material. Patients at increased risk are patients having low eGFR, diabetes, congestive heart failure, EF less than 40%, hypertension, anemia, advanced stage, proteinuria, and gout. You have to remember that gadolinium is not a safe alternative to contrast agents. So management is mainly prevention with hydration therapy, at least 1 ml per kg per hour, 6 hours before and continued post-contrast use. Renal perfusion is decreased for up to 20 hours following contrast administration. So intravascular volume expansion maintains renal blood flow, preserves nitric oxide production, prevents medullary hypoxia, and enhances contrast elimination. These other therapies are not routinely used and they have not been found to be very useful. Now, the other case is an emergency procedure for ruptured aortic aneurysm. Patient was admitted in another hospital with a suspicion of tubercular spine with paravertebral abscess. There was a bloody tap during biopsy and referred for ruptured aortic aneurysm. You can see that in the chest X-ray, left lung is collapsed. Presentation was pain from expanding hematoma, respiratory insufficiency, agitation from hypotension, and metabolic disturbance. But there can be many symptoms of acute aortic syndrome. One is asymmetric blood pressure between limbs because of compromise of branch artery flow, stroke due to carotid or vertebral artery involvement, breathlessness due to compression of trachea or bronchus, congestive heart failure from aortic regurgitation or cardiac tamponade or hemothorax, hemoptysis if it ruptures into lung parenchyma, hoarseness is due to recurrent laryngeal nerve compression, oliguria due to malperfusion of one or both renal arteries, paraplegia due to spinal malperfusion attributable to intercostal artery involvement. Shock may be because of cardiac tamponade, hemothorax, frank aortic rupture, severe AR, or myocardial ischemia. Bowel ischemia also can occur, or bowel bleed due to malperfusion of celiac or superior mesenteric artery. If it is anatomically feasible, EVAR is preferred over repair for a ruptured aortic aneurysm. So in our patient, TVAR was performed. You can see in this the saccular aneurysm arising from the undersurface of the arch of aorta. This is the saccular aneurysm, and after stent deployment, that has been excluded from the flow. So intraoperative management in emergency EVAR is, this is not a case for neuraxial anesthesia. We can start under local anesthesia and later maybe switched over to GA after stent placement. Because if we give GA before stent deployment, the relaxation due to general anesthesia can lead to expanding of the uh, uh, collection because of the loss of tamponade effect. So cannulation of excess vessels and insertion of an expandable aortic balloon into supraceliac aorta for ruptured abdominal aortic aneurysms can be done under local anesthesia. We need to collaborate with surgeon during induction, movement of aortic occlusion and placement of stent graft. So patient may not tolerate if patient has severe pain or has respiratory insufficiency or limb ischemia or agitation from hypotension and metabolic disturbance. The hemodynamic goal is to maintain adequate spinal cord perfusion. So we maintain a permissive hypotension to a systolic blood pressure up to 80 millimeters of mercury. Sudden surges of BP may be controlled with esmolol boluses, or decrease can be treated with phenylephrine boluses. After stent deployment, now mean arterial pressure is increased to 110 or above to 90 to 100 to maintain adequate spinal cord perfusion. The other measures are to have selective hypothermia, CSF drainage, or use of hydrosteroids or mannitol. Now, intraoperative fluid resuscitation and blood conservation. If hemoglobin is less than 10 grams and blood loss is ongoing, we have to give plasma, platelet, and Paxil in the ratio of 1:1:1 or warm flesh whole blood. Then withholding plasma or platelet transfusion until surgical repair is complete is not supported by clinical evidence. We should not wait in these patients to give transfusion. Now, coagulation management, all these patients require heparinization, usually 1 mg per kg. After excess vessels are cannulated to maintain ACT of 2 to 2.5 times normal up to 300 seconds. Surgeons may request reversal after procedure with protamine. Now, risk factors for spinal cord ischemia are long stent grafts, inferior mesenteric artery being occluded during infrarenal EVAR, hypoperfusion, thrombosis, microembolism, and this could be due to prolonged procedure time, extensive manipulation of the intravascular catheters, or patients who had previous repair. So this artery of Adam-Kivis arises directly from the aorta from T5 to L5 level, commonly between T9 to T12. And causes for paraplegia could be non-reimplantation of intercostal arteries, graft coverage of left subclavian artery, compromised flow to collateral blood supply of spinal cord by embolization, blood loss, and perioperative hypotension. So, we need to monitor standard ECG in direct blood pressure, CVP, saturation, EtCO2, respiratory gas analysis, this monitoring temperature and ABG. In selected cases, CSF pressure, NIRS or evoked potentials, motor and sensory, transcranial Doppler, EEG, transesophageal echocardiography, and pulmonary artery catheter may be required in special cases. So measures to optimize spinal cord and end organ perfusion is either with CSF drainage to increase mean arterial pressure more than 100, transfuse hemoglobin to more than 10 grams, volume resuscitation, and cardioversion for tachyarrhythmias. Spinal cord perfusion is mean arterial pressure minus CSF pressure. So to improve perfusion, we increase the mean arterial pressure and decrease the CSF pressure. Preoperatively, drain may be used for complex EVAs, and post-procedure also in a patient with risk for spinal cord damage, post-operatively also it can be inserted. There are various complications. I'll briefly discuss about endo leaks. Endoleak is failure to exclude the aneurysm from circulation after device deployment because of persistent leak of blood into the sac. So there are various types. It could be just during the procedure that the sealing is not adequate, so blood continues to flow into the sac, or later because of collateral development and blood returning to the sac. The problem is these can enlarge the aneurysm even after stenting and lead to rupture. So 5 types are there. Of this, 1 and 2 are more important. Management is conservative with increased surveillance, coil embolization, placement of graft cuffs, ligation of feeding arteries, and open repair if these measures fail. The other complication could be abdominal compartment syndrome. It can happen after both open surgical repair or EVAR in 7% of patients. Predictors are use of aortic occlusion balloon, coagulopathy, massive transfusion, conversion to aorto-uni-iliac device. Occurs in the hemodynamically unstable patient with a large retroperitoneal hematoma. Diffuse visceral edema results in intra-abdominal hypertension, multiple system organ dysfunction, oliguria, peak airway pressure, increased hypoxia, hypercapnia, hypotension, and decreased cardiac output. Early recognition and surgical decompression is required. Briefly about anesthetic consideration for ascending aortic endovascular procedures. Preoperatively, collaboration with the team is important. Pre-induction arterial line site has to be decided. NIRS and transcranial Doppler if required. Patient has to be kept warm. Blood product availability is checked. Perfusionist should be available in the theater with circuit primed. Post-induction, patient is monitored with CVP, transesophageal echocardiography, and arterial blood pressure. Prior to stent deployment, confirmation of guide wire in true lumen is done with PE and confirm proper stent deployment. Post-deployment, we have to maintain blood pressure, rule out aortic regurgitation, coronary ostial occlusion, dissection, pericardial effusion, wall motion abnormalities, and LV function is assessed with TE. Post-operatively, rhythm abnormalities have to be monitored. Tamponade wall motion abnormalities are checked again with the TE. So there are 3 zones in the ascending aorta based on these zones. The selection is done only for B or C level tear for aortic dissection, subjecting for TVAR. This patient came with ascending aortic aneurysm. There was a pulsatile mass seen, and this was actually managed with open surgical repair. Patient had to be put on percutaneous femoral bypass, and then sternotomy was done. LV was vented through mini thoracotomy, and it was a complex procedure. There are vascular society guidelines for postoperative management. So ICU care is required for significant cardiac, pulmonary, or renal disease, and for who develop significant arrhythmia or hemodynamic instability during the procedure. Postoperatively, ST segment monitoring is required who are at high risk, and troponin if STT changes appear. Thromboprophylaxis is required. Intermittent pneumatic compression and early ambulation for all patients. Threshold for blood transfusion during or after aneurysm repair is at HB of 7 or below in the absence of ongoing blood loss. So in conclusion, EVAR is not a low risk procedure, even though it is minimally invasive, but it carries 1/3 the risk of operative mortality. EVAR is advocated for usually elderly patients who are less fit, and open repair may be considered still for younger patients. And EBAR is associated with more long-term complications and re-interventions than open aneurysm repair. These are the references. Thank you. I hope I was audible.
Yeah, that experience was intermittently spoiled by a decrease in audio quality, but overall we could get the message. Thank you, Dr. Parimala.
Thank you.
We'll take questions towards the end. Next, I invite Dr. Subhendu Sarkar, Head Cardiac Anesthesia, Dezun Hospital and Heart Institute, Calcutta. He'll speak on hemodynamic monitoring. The part one of this topic will be presented today. Over to Dr. Subhendu. Dr. Subhendu.
Hello, sir.
Yeah. We are ready for you.
Yeah. Is it visible, sir?
Yeah, I can
Yeah,
see.
fine. Thank you. Thank you, Meenakshi, sir. Thank you, Pudukkottai branch, for organizing such a nice academic program. And it's very nice to see a continuous academic program, and students will be very much benefited. So today, after discussing with Meenakshi, sir, we have planned that the hemodynamic monitoring, it is as such, doesn't that much will ask probably in the examination for the MD students. But obviously, if after completing the MD, if we want to establish ourselves as a complete intensivist, as especially the intensive care unit, I think from the very beginning, we should start gathering a bit of hemodynamic monitoring knowledge from the beginning. So I am divided my entire presentation in two parts, the hemodynamic monitoring part 1 and part 2. So in part 1 monitor, just 1 second. I don't know why the slides are not progressing. Yeah. All right. So I want to start with, I hope a couple of my postgraduate friends are also there. So my entire presentation in coming 25 minutes or so will be based on much of video presentations and some of the interesting thing. What one of them I got it today morning, I thought I should put a small video clip so that you can have a nice discussion. Although some might consider the electronic devices is the only cardiovascular monitor, but the fundamental basis for the circulatory monitoring remains the eyes, hands, and ear of anesthesiologist. I always start my presentation with this slide because honestly speaking, and hemodynamic monitoring and cardiac intensive care, I personally feel I don't want to bring myself in a much of conflict one. A cardiac anesthesiologist can do, or an anesthesiologist can do much better in comparison to others. We started our journey of hemodynamic monitoring with putting the finger on the pulse, and the journey will continue. We have the history of monitoring with this sphygmomanometer. I'm not going to details of that. This is the way we actually started our hemodynamic monitoring. And obviously, every perioperative physician will agree with me that every day, whenever we deal with patients in operation theater, all also in the intensive care, these are the 7 parameters we actually start with. And until and unless, it's my suggestion that to all my postgraduate friends and others, that we should not jump to any galaxy things and other until and unless we complete the basic groundwork of these 7 things to check routinely for every patient. Now, before we go to the basic portion, basic hemodynamic monitoring, we want to spend few times, at least 5 to 6 minutes time, for understanding the basic concepts behind it for all hemodynamic monitoring in the circulatory system. And being an intensivist, you have to reach to a place where the assessment of the oxygen supply and demand come to a very basic level in an equivalence balance, and then you'll be able to announce that yes, your patient is a bit stable. So if the goal is reached, okay, no problem. And if the goal is not reached, we need to identify where is the diagnosis and what's the problem lies, and we need to find out the therapy accordingly. So actually the hemodynamic monitoring concept is based on this picture. We need to establish the adequate oxygen delivery in comparison to the demand and consumption. And these are the different types of monitor, starting from the basic monitors to the advanced. Even right now, I am working a bit on this artificial intelligence also. So we went up to that level, but our exact aim to reach or to go to the summit to reach this particular picture. Now, how the behavior of the oxygen consumption and the oxygen extraction comes. The oxygen consumption, suppose it's very often that whenever we start the pulse oximeter tone, just went to the level of the bass guitar like da, 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 something like that, we just raise our alarm and start doing things and other. But actually the story starts far, far before that. So this is not only the oxygen demand and supply ratio equitable distribution, but simultaneously, we also need to understand through these monitors in a completely evidence-based way when the problem has already been started, and before occurs something, we need to find out, we need to hold, we need to stop and do the proper therapy on the management. Usually the oxygen consumption and the extraction goes smoothly like anything. And suppose the patient start getting oxygen stopped. Still the body reserves maintain a bit, but after that it starts falling. And this dependent area, this red portion, we want to prevent by using the hemodynamic monitor. The balance of oxygen delivery and consumption, there are a lot of factors in comparison to general factors and other factors. So older age, body weight, current medical history, previous history, microcirculation disturbance, volume status, tissue oxygen level, oxygenation, hemoglobin level. These are the different things we actually put a bit focus on before managing by using the different hemodynamic monitoring. So we all agree that the purpose of the circulation is the cellular oxygenation. For an optimal oxygen supply at the cellular level, the micro and the macro circulation as well as the pulmonary gas exchange have to be optimally balanced. And next to the cardiac output, hemoglobin and mixed venous oxygen saturation plays a very central role, and no single parameter provides enough information for full information and assessment about the oxygen supply and the demand. So in general, for example, if we take in septic patients and hemodynamic failure, there are actually the three components. One is hypovolemia, vascular tone depression, and myocardial depression. And these are the things, this importance of assessing the degree of each component to select and apply the best therapeutic options. We have the fluid, vasopressor, and the ionotropes. Grossly, we can divide the entire range of the hemodynamic monitoring in non-invasive, less invasive, and the invasive one. Okay, so the goal of the monitor, this slide I found very important to assure the adequacy of the perfusion, early detection of the inadequacy of the perfusion, to titrate the therapy of specific hemodynamic endpoint, and lastly, to differentiate among various organ system dysfunction. This is actually the ultimate fourth important goal of hemodynamic monitoring. So it is obviously physiologically based and goal oriented. So the first portion is over. The second portion, before we go to the basic monitoring, the first thing is a monitoring setup. See, my friends, particularly to the junior colleagues, until and unless you are becoming a good technocrat, a good technician, you won't be able to be a good cardiac anesthesiologist or cardiac intensivist. So from the very beginning, if you start your grooming for hemodynamic monitoring section, you should start your journey from the monitoring setup. So monitoring setup, usually for any type of monitoring. So, madam, in his presentations, you have very nicely described the CSF monitoring, the CSF drainage issues, and other whatever may be that. It can be an arterial, PA, CVP, CSF pressure monitoring, whatever may be. Every monitoring system has a coupling system, a transducer system, and a flash system. So whenever you will advise, you have to check, or even suppose you gave a patient is getting monitored or a central venous pressure or a arterial pressure or a PA pressure. Suddenly you got a call, doctor, we can't see anything. The traces are not coming. It's not getting, it's getting damped or something like that. The first thing you need to check these three systems. Near about 65 to 70% problem usually gets solved if we've been able to check the entire system, particularly under these three headings. So let's check a video. For the seniors, it's just
So, Dr. Subhendu, is there a voiceover for this video?
Sir?
We are seeing something, but
Oh, you are not been able to see the listen the voice?
no.
Oh, I don't know why.
So could you please go over?
When, Dr. Subhendu, you can explain because video voice is not there. No, you are muted. Dr. Subhendu, you are muted.
Yes, sir. Actually, I have been able to listen the video voice, but you are not. Okay.
No, audio is not there. Video is seen.
Okay. So actually, in this video, where my pointer is, I am describing the three systems. One is the transducer system, one is the flush system, another is a coupling system. Now, what I am showing is how we prepare the heparinized flush system. So this is how the flush system is being prepared. So we can start giving pressure to the back. We can see the amount of the pressure. It is near about 200. You can see the colored code, the green zone, the entire flush system is being prepared. And now the yellow one is an arterial connection and blue is the venous system. We can connect it, can be central venous catheter, can be connected with the pulmonary artery catheter, and this is the transducer system, and this is the coupling system. Okay. Now the last step of monitoring assemble. This is with the coming with the from the monitor, the cable. Right. So now you can see now I am connecting. I asked my technicians to connect the arterial one and with the venous one. You can see the same connections here. It's very easy. So no need to give much screwing ties or anything. So one of the connection is connected with the venous system, another is an arterial system. Now the monitoring. So now this video shows the entire preparation of the flush system, transducer system, and the coupling system. This is the transducer system. So now we need to check the next one. So the assembly is ready. Now, before you start puncturing either an arterial line or a central venous catheter or the PA catheter, whatever may be, you need to check another important thing, that whether it is transducing properly in the central monitor or not. It is simple. By checking the arterial line or the central venous, which is the coupler system, we can see a waveform in the monitor. So we can check the entire integrity of the system, that the heparinized flask system, the transducer system, the coupler system, and the electromagnetic signal transition to the monitor. The entire thing is in one loop and totally been checked, and it's all working perfectly. Now I am showing you the video. You can see I've asked him to shake the line. So he has started shaking, and I'm showing, you can see the resonance change. And now the arterial system has been connected. Okay. The next one is the leveling and the zeroing. The leveling, obviously, it's mandatory for everybody who is performing. You need to, before and after insertion, you need to level your transducer after the patient's bed or the transducer movement, and the zeroing performed before insertion and return. The flavostatic axis is the fourth intercostal space, mid-axillary line, which is in the level of the atrium. And obviously, with the change of the head positions, you also need to change the position of the transducer. So, before we go to the next phase, the damp waveform. This is one of the very frequent things, the damp waveform that comes. You need to check these 5 points always in your mind, whether your pressure bag is inflated properly, what is if there is any repositioning of your extremity or the patient, you need to verify the appropriate scale. You need to flush or aspirate the line properly and check or replace the module or cable if at all needed. So all the points has been given in according to the importance, because the pressure bag, I put it in the first point because this is one of the commonest thing. We often found either the pressure bag is not very well inflated or the heparin flask has been exhausted, something like that happened in the flask system. So if we go on excluding one after another, in majority of the troubleshooting in the hemodynamic monitoring, the basic portion is being taken care of. So the third question is an arterial cannulation. The arterial cannulations, we all know from our clinical practice that these are the sites where we can put an arterial line, but the radial and femoral artery, very rarely, for if we got fully stuck in at least one or two patients out. In one or any problem, sir?
Dr. Meenakshi sir.
Should I continue?
Yeah.
I have muted him. Please continue.
Okay, fine. So these are the all sites where we can put an arterial catheter. Radial and femoral, obviously the commonest site. But in my clinical practice, at least 1 or 2 in 100 patients, I have to put a brachial arterial line, either because in the cath lab, the radial arterial site has been destroyed, and other something we have not been able to get a pass. But even if I have to put a brachial arterial line, which is absolutely not very well advised, I try to take this arterial line as early as possible in the intensive care. Now, for a perfectly put arterial line, these are the areas you need to find. If we follow my pointer, the A and B, this is the anacrotic limb, this is the dicrotic notch, and this is the dicrotic limb. If the arterial waveform comes like this is a normal waveform. If the arterial waveform comes like this is called an over-damping of the waveform. And if the arterial waveform comes like this is called an under-damping of the waveform. And these are the two very tricky situations. You need to get rid of this. This is number one. Until and unless you have been getting to rid of this, you won't be able to get the proper value. Now, I am showing you a video, a small clippings that I have taken just 3-4 hours before today. I usually put radial and femoral arterial line in all my patients. And now I'm showing you, see the video. Here the femoral and radial artery is being very nicely pointed out. I am freezing the video. You can see this is the radial arterial line trace, and the blood pressure is showing something around 129/66 with a mean pressure of around 83 to 84. Now, I am turning from radial to the femoral arterial line. You see the trace changes. You can see that now I am monitoring the femoral arterial line, but the mean pressure, you can see it is around 86, 84, but the systolic pressure is 170. Again, I am converting to the radial arterial line. You can see the systolic jump to 130, but the mean pressure is like this. My intention to show this video to all my junior colleagues is that whenever you will gradually enter, today we are being planned to discuss only the basic portions of the hemodynamic monitoring. That's why I started from that, absolutely from the preparation of the transducer system. You should not jump on the systolic, what the systolic pressure is showing. The most important thing is the mean pressure, number one. And number two, in majority of the time, even if your system is entirely configured and absolutely perfectly flushed and everything, you can have the damp waveform because of the difference in the vascular tone. So don't worry. If we have the facility of radial and the femoral arterial line, these two distant sites, you'll be able to take care of that. But even if you come to the practical, it is obviously not possible always. Just to rule out the damping issue, you need to put two arterial line. Absolutely, this is not acceptable. But I just wanted to show you, this is the way how we should actually take care of the damping issues and what are the value we should actually give importance. Okay. So this is the flush test, how we flush usually our line. And if we put the arterial cannula in the different sides of our body, this is the different sides of the crest. Because of there is a difference of the systemic vascular resistance. You can see the dicrotic notch has been shifted gradually from the ascending aorta to the abdominal aorta to the radial artery. Now, this is one of the extremely important sites for all intensivists, specifically my student colleagues. Whenever you will see an arterial trace perfectly put in a monitor, it gives you a lot of information. The number one, if we go to the slope of upstroke, it gives the contractility of the heart. The area under the contraction, the AUC, is the ejection phase. It actually gives you the stroke volume. The position of the dicrotic notch, if it is low, it is the low systemic vascular resistance. If it is on a high, it's on a high after low. And if the slope of descent, depending upon the steep, you can identify what is the systemic vascular resistance pattern of your patient. So if you start practicing observing an arterial wave, nicely done, nicely maintained, very carefully, you'll be able to get out so many informations, not in a digitally valued another, at least the contractile status or the stroke volume status of the heart. And based on this, whenever in my next class, the part 2 will go to the advanced monitoring system, we'll have the systolic pressure variation, pulse pressure variation, stroke volume variation. These are all being calculated, rooted from the basic hemodynamic monitoring. These are the different contraindications. These are the different methods. We can put an arterial line with a direct cannulation method, transfixation, and the self-injury method. This is a video how I usually put a radial arterial line. This is the position. And one thing I haven't mentioned, it is extremely important for your examination purpose also. Whenever you tell something about your arterial cannulations and other, never and never forget to mention about the Allen's test. Okay, this is extremely important. So this is how I position an arterial, the hand for a radial arterial line axis. This is the painting. I'll request our chairman, Sir Sunil, sir. Sir, whenever my time is up, you please mention me. I'll stop. Rest of the portion, I don't want to extend my lecture unnecessary because everybody finished their lecture in time. Okay.
Yeah, please continue.
Yeah. So this is how I
you have 10 more.
Local infiltration is been given. And this is a very well advanced. Everybody knows this is an arterial cannula, a flow switch method. And this is just, you can say this is just a revision, nothing to teach about you, about how to put an arterial line. You all know very well, probably the junior people when become senior, you will be able to do by yourself. You can see the back flush. Yes. And you just need to slide a bit, and it is just to show you the flow. Right. Okay. Now the next one is, this is the way of my fixation. I just want to share with you. I'm not going to train or other thing. This is actually the way how I fix, because I get a bit scared, because during the transport, during the bed care, movements and other, your arterial line fixation is extremely important, because something happens, you only the person who need to take the entire responsibility. Currently, after changing a lot of steps and other, I am just practicing. This is the method, and we can easily understand the entire video and everything. I am the performer, so there is no. Yeah, this is a simple, and I found this is an extremely good method of fixation. And yeah, aspect. Right. Going to the next one. This is the femoral arterial line axis, Seldinger technique. You can see the spot, the guide wire, and this is an arterial catheter. Right. I'm speaking. These are the different complications of an arterial catheter. As an intensivist, you need to take care of this. If something you are assuming is going to happen, another, you instant need to take action. The next one is a central venous catheter. Central venous pressure, we all know the central line, or we'll discuss a bit about the pulmonary catheter also. Only the basic variety today. Advanced, we'll go to the next one, next class. The normal value is 2 to 8. Low CVP, that's been hypovolemia. High CVP means over high pressure. Central venous pressure, we all know there are 5 ways: ACV positive and X and Y descent. And ACV positive and XO and Y descent, how it happens and everything, these are the very important questions for your examination also. And obviously, in your clinical practice also, if you have been able to identify the waveforms, it actually gives a bit of information to your clinical practice. This is a very important slide. You can see the zero transducer to the patient's phlebostatic axis. Always read the central venous pressure at end expiration. And central venous pressure is a direct measurement of right ventricular end diastolic pressure. So these 3 are very practical, important points whenever you are using central venous pressure as one of the tool of your basic hemodynamic monitoring. So I'm not spending much of time that how the waveforms are prepared and others. This is a very important question for your examination also. Rather, we'll go for some applied importance regarding the central venous pressure is concerned. Now you can see, just one second. Now you can see the above one is an atrial fibrillation. This atrial fibrillations where it's irregularly regular, and this is the one where the A wave of contraction, that is an atrial contraction, is not there. So ACV positive and XY descent, the A wave in the central venous pressure is actually absent in atrial fibrillation. Next one is then isorhythmic atrioventricular dissociation. You can see this is how the dissociation wave comes. This is an extremely important wave, and I think all my cardiac anesthesiologists who are being here present, they will agree this is one of the very indicating wave for all the cardiac anesthesiologists. Whenever we come on bypass or whenever we find a patient suddenly going to the nodal rhythm and others, it helps us. Even a central venous pressure, actually everybody must agree, the cardiac surgeons has a very nice habit of not accepting the nodal rhythm. Even the nodal rhythm takes it as a, oh, its atria is contracting. I think this is the only thing. But by looking to the central venous pressures, we can easily identify, even correlating with the heart also, whether the patient is having the atrioventricular dissociation or not. Okay. So this is the tricuspid regurgitation. This is the CVP, how it looks like. And this is the tricuspid stenosis. This is one of the important thing, that central venous pressure is relative to the atmosphere pressure decreases during the inspiratory phase, that is a spontaneous ventilations. It reverse happen during the positive pressure ventilation also. Even by ventilatory pattern, we can assess by seeing the central venous pressure with the patient is on ventilator, we can assess the volume status of a particular individual. This is, you can see the classical way the patient is having tricuspid regurgitation, central venous pressure. So for all my junior colleagues, this is one of the very important thing. You always remember that in atrial fibrillation, there is loss of A waves and prominent C waves. FE dissociation is there, where we can see the canon A wave. The tricuspid regurgitation, there is a tall systolic CV wave and loss of H descent. In tricuspid stenosis, tall A wave. If there is a right ventricular ischemia, we will have a tall A and V waves and MW configuration. Pericardial constrictive pericarditis, we have a steep X and Y descent. In cardiac tamponade, dominant X descent and respiratory variation during spontaneous and positive pressure ventilation, and it should be measured always and always at the end expiration. So central venous pressure actually, apart from its value regarding the volume status is concerned, give us a lot of information to us. So my today's last presentation, last portion is a pulmonary artery catheter. The pulmonary artery catheter is also called a PA catheter or a Swan-Gunch catheter or a Swan. It is a 110 centimeter long catheter. These are the discoverers of Swan-Gunch catheter, William Gunch and H.J.C. Swan. Pulmonary artery catheter is actually having 8 to 9 varieties. Till now, honestly speaking, I am very much fond of using pulmonary artery catheter. I have put more than 3,500 catheters till now of different varieties. Even fortunate to use almost the extreme variety which is available right now, CCA combo B, that I'll show you in the next class how I use it and what are the parameters. If we go on increasing the variety of the pulmonary artery catheter, go on in different advancing, apart from the systolic, diastolic, and the mean pressure and the pulmonary capillary wedge pressure, these are the 4 important parameters that we get from the all variety of the PA catheter, starting from the simple to the highest of the variety. But whenever we go on increasing our variety of the PA catheter, we go on advancing, we'll be able to see some of the measured value and some of the calculated value. And these are extremely important advanced hemodynamic parameters when you are actually going for a depth analysis of any patient situations in an evidence-based manner. These are the candidates of pulmonary artery catheter. And obviously, these are the contraindications. Any big pathology in the right heart is a contraindications for the PA. PA is being methed with a lot of complications, issue and other. It's an extremely invasive procedures. You need an expertise and everything. I fully agree with all of controversies. I address the controversies, TOE, everything. But to me, practically, if you come, I am still the fault, and I'm still, to me, the pulmonary artery catheter I found a gold standard. And till now, by God's grace, I didn't face any complications by putting a PA catheter. These are the different distances of the pulmonary artery catheter. If we put it from the interjugular, femoral, or the subclavian vein, actually at what distance it reaches the PA. This is a small video that I want to share with you. This is actually a video. This is called advanced venous access. It is a 9.5 French catheter. It is not available now. I used it, but it is probably from last 2.5 years, it is not available. This is a catheter where a triple lumen and a pulmonary artery catheter, pulmonary catheter sheath has been impregnated in one go. So this catheter is not only important in a single puncture, we can do it, and simultaneously through this, the PA catheter can be pushed, and the tubes are so big. Even I have an experience to start a dialysis, or in few patients, I started the total parenteral nutrition also. You can see such a big catheter it is. Okay, I'm escaping the video because of the lack of time. You can see this is how we put the catheter. Another, the only thing is such a big catheter of 9.5 French, you need a bit of practice because your patient is going to get heparinized, or even in an intensive care also, your patients can have a bleeding problem and other. So for putting this type of such a big bore of catheter, you need a bit skill and practice for putting it. You can see this is how the catheter looks like. Through this, the PA catheter has been given. And this is the big catheter. You can see a small nick and the entire handling of your dilator, it's enough. See, it's all depend upon the practice and other, because even in my everyday practice, I usually don't use any knife for putting a simple central venous catheter. Your dilator handling is more than enough. Now, a small video about how we put the pulmonary artery catheter. Usually, for all PA catheter, I put the two central venous line. The first one is for the triple lumen central venous catheter, and the second one for the sheath. The sheath is actually 8.5 French diameter. Through this, the 7 French pulmonary artery catheter has been negotiated. You can see that I've already put the triple lumen. You can see this is the dilator, and this is the. You can see this is a sheath is prepared. Sheath. So I am just through the guide where I am negotiating the sheath. This is it as simple as that. As very, very small nick, no bleeding, nothing. So your area will be absolutely clean. So now the thing is regarding this PA catheter floating. First one is practice. I'm not going into this. It is a flow directed catheter. The flow directed catheter, once we reach to the right atrium, we inflate the balloon. And once we inflate the balloon, it actually floats in the blood. So with each contraction, the catheter goes from the right atrium to the right ventricle, crossing the tricuspid valve, from the right ventricle to the pulmonary artery, crossing the pulmonary valve, and we try to block the pulmonary artery with the balloon to get the pulmonary capillary wedge pressure. So these are the steps, and obviously you go on have to negotiate your catheter very gently with each contraction of your heart. And obviously you need to zero it properly, you need to flush it properly, you need to check the balloon status, whether the balloon is deflating properly. And if you can follow my pointer, this is a syringe of 1.5 cc capacity. Even if you want, you won't be able to give air more than 1.5 ml. This is one of the safety features that prevents a balloon rupture, accidental balloon rupture inside. So let's complete the video. So I am inflating the balloon. You can see the balloon inflated. Flow directed, that is why it is called the flow directed catheter. And I'll negotiate the catheter through this. This is the 8.5 French interflex with this right trim. And this is the till second marking you can negotiate. It will reach to the central venous. So till the second marking, the catheter will act as a central venous catheter, and then it will go to the pulmonary artery. So this balloon inflation, this white one is for proximal infusion if you want to give, and you can see this yellow one that is connected with the transducer. Now I am flushing the catheter. You can see the flushing has been completed. Now I am negotiating the catheter. So I started negotiating. So negotiating, I advanced to the second mark and I stopped. Now I have projected my camera to the monitor. So now seeing the monitor, will see initially the central venous pressure waveform. It will convert to the right ventricular waveform. Then it will convert to the PA waveform. Then it will convert to the pulmonary capillary wedge pressure waveform. Okay. So now you can see this is the central venous pressure waveform like. So you are seeing 3 value as because it is the systole diastole mean configuration has been done. That's why. So I am trying to negotiate to the tricuspid valve to the right ventricle. So you will see the change of the waveform. You can see the change of the waveform. It's the box waveform, and the best way of diagnosis. Suppose if your patient is having some pathology like ventricular septal defect, or your patient is having extremely high right ventricular pressure because of the severe pulmonary arterial hypertension, you may be a bit confused that whether I am actually reached the right ventricle or I actually went to the pulmonary artery. It's nothing like that. The easiest way, you should always focus on the diastolic pressure. So your diastolic pressure is the guideline whether you are actually in the right ventricle or not, apart from ectopics and other. Okay, and the thing is, you can see the diastolic pressure here is something around 1, 2 or something, right? You can see the 31/1. So now I am trying to negotiate the catheter from the right ventricle to the pulmonary artery. Now I cross the pulmonary valve. You can see the change. Suddenly the diastolic pressure, as you can see, the single digit diastolic pressure has increased. So I am reached the pulmonary artery. Now I'm trying to block the pulmonary artery by wedging. Now I am wedged. Yes. Now wedged very nicely. It has been wedged. So we can see the wedge pressure. So by this, we can see the another thing is, after completing your wedging by seeing the systolic, diastolic mean pressure as well as the pulmonary capillary wedge pressure, never and never allow your declare your procedure complete until and unless your colleague or technician who is in the transducer side have a very smooth and nice aspiration and flushing, zeroing then only. Because this is an extremely important for your smooth aspiration and very fine aspiration, smooth flushing, zeroing. These are extremely important because you may have to change. Sometimes you are overweight or something, you may have to withdraw a bit. These are the all things you should done on spot. It is better not to handle much the pulmonary artery catheter after you have put it. So you can see the it's coming very smoothly. So you can see the pulmonary artery catheter. Now it is fixed. So this is the triple lumen, and this is the extension of the shape. Okay. So these are the normal value, and we have that there are different conditions where we have the high pulmonary artery pressure and the low pulmonary artery pressure. Now some of the practical points. Now you your pulmonary catheter is ready for monitoring. If you want to monitor the proper pulmonary capillary wedge pressure, actually the catheter should be in a zone 3 placement. And we all know the lung zone has been divided in the thoracic portion, you know. So these are the zone 3 where the pulmonary catheter should be actually placed. But how will you know it is in the zone 3? Number 1, clear waveform, not damped. That's why the aspiration, smooth aspiration, flushing and zeroing is extremely important. Number 2, there is no high variation in the pulmonary capillary wedge waveform during the respiratory cycle. The pulmonary artery pressure mean is more than the wedge pressure, and wedge pressure decreasing not more than 50% if there is a reduction of the PEEP level when the patient is on ventilation. The SaO2 of the pulmonary artery pressure blood and SaO2 arterial blood is there, and PEEP, if you have been able to do an X-ray, chest X-ray, it's not mandatory always after putting a PA catheter or central venous catheter doing an X-ray. It varies in the institutional protocol. I don't do it regularly. If you'll be able to see the tip of the catheter lies below the level of the left atrium at the lateral chest X-ray. And obviously, there is free aspiration of the blood from the PA lumen with balloon inflated. So these are the extremely important 6-7 points where you've been able to find out, yes, my catheter is in zone 3 place, and whenever it is a zone 3 placement properly, what the value you are getting is a perfect real-time value of your pulmonary vascular parameters. So these are the different clinical significance. Obviously, from the pulmonary capillary wedge pressure, we can go to the left atrial pressure or the left ventricular end diastolic pressures. And there is a bit confusion regarding the mixed venous oxygen saturations and the right heart saturation. See, the mixed venous oxygen saturation is actually of much more clinical significance regarding very early detection of the low cardiac output. And if you are fortunate to have a pulmonary catheter in arterial catheter in place, and if you have been able to send a gas analysis from there, you will be able to get the exact mixed venous oxygen saturation. And whenever I put PA catheter, or definitely not all the patients, selective patients in cardiac intensive care, I usually try to do a mixed venous oxygen saturation. Meenakshi sir is calling, so I have to finish it first. So overweighting of the pulmonary catheter, it is measured at the end expirations, and how to read the wedge pressure, I will discuss in my next class. Thank you.
Thank you, Dr. Subendu. All three speakers delivered excellent lectures, very informative. So I'll just go on to questions. There are a few questions from the audience side. The first one is to Dr. Rohini. I hope you saw the question, Dr. Usha.
Oh, yes, sir, I did. I did see the question. She's asked how long you can keep an IABP in for.
Yeah.
So to address this, I would say you will keep an IABP in for only as long as it is necessary, because it is not without complications, as I already mentioned. So when IABP is in place, we continuously monitor for the limb ischemia, urine output, if there is any skin discoloration in the limb, peripheral pulses, daily monitoring of platelet count, because it can be associated with thrombocytopenia also. So we do watch for these complications, and anything, if the limb is developing continued ischemia, compartment syndrome, but then it will be inevitable that you will have to take the IABP out. So in saying that, usually the duration of keeping in IABP varies between, say, 1 to 7 days, and not more than that. So take it out as early as possible, as your acidosis settles, as your lactates start coming down, as your tissue perfusion improves, as your myocardial recovery occurs. Keep it in for as little duration as possible. And that's about it. I hope that answers the question.
Yeah. Yeah, that's the answer. The benefits of IABP needs to be weighed against the risks from retaining the IABP beyond I mean, it's not required beyond the period from at which the cardiac function recovers. But even while it is on, we continuously monitor for adverse events from the use of IABP, predominantly limb ischemia, because the limb in which the IABP is inserted. So that can suffer from decreased blood supply, and can even progress to gangrene. So if the patient...
Sunil sir, we have this Doppler is already inbuilt in the IABP machine. So it should be a regular habit for everybody to check the Doppler before putting, after putting, at least once in a day we can check the Doppler by using. It's already there in the machine itself.
Yeah. So there are we have to monitor the blood supply, and we have methods to do so. So the next question from the audience side, Dr. Bharti Mohan asks, are these sessions uploaded in YouTube for viewing them later? I think this has been answered by Dr. Meenakshi Sundaram. To Dr. Subendu, what disposable transducer system would you recommend in the Indian market?
This is actually a question of conflict of interest. There are a couple of companies, they prepare it. It's not only the recommendation of we can use any of the transducer system. The most important thing is we should actually take part in checking the integrity of the system, what I have described from the very beginning, and we should make it a habit. If we practice it generously, then I think any standard company disposable for monitoring the invasive lines are more than enough and standardized.
Yeah, we go for a brand that works well. I mean, like there is no
We
break.
use Edward Life Science is from the very beginning. I'm using Edward Life Science.
Yeah, I would not go as far as dropping names, but the system has to be, it should have good integrity. There should not be leaks,
Exactly.
breakages. I mean, the quality of the build of the product is important. So I'm
Yes.
sure there are enough in the market.
Enough. There are 4 or 5 companies that are.
Yeah. And the product price range is also widely varying. There are some good
Yeah.
ones which are not pricey. There are some very good ones which are pricey.
Sunil sir, actually there is a lot of difference. You work in one of the premier most organization in India, and I also work in a famous hospital, but it's a corporate hospital. Here, in the corporate hospital, the stories are completely different. So lots of negotiations and other things that obviously is there. So we always try to recommend at least a standard company, which is the points you have already mentioned. We need to check there should be a proper integrity, the quality is good, we can use it for a long durations and other. And obviously our responsibility also comes. We should make it a habit of checking all the things regularly.
Again, the next question is to Dr. Subhendu. This is from Dr. Muthu. Should we check the arterial BP with the NIBP every time we do invasive?
No. Not at all. If you have a issue with the damping, suppose you put an arterial line nicely, and after one day or after some time you are seeing you are not been able to appreciate the waveform nicely, you are not been able to see the wave components, your wave was actually changed, getting damped rather than over damped or the under damped, then obviously you can cross check once with an NIBP. But there is no need at all for a perfectly put arterial line to cross check with that.
And again, we have this question from Dr. Muthu Kumar. Can we use temporal artery in case of coarctation of aorta in case we don't get the radial artery on the right side? Radial or brachial artery on the right side. That's the question.
I hand over this question to our chairman, sir. Honestly speaking, superficial temporal artery, I don't have much of experience. In coarctation of aorta, I have done plenty of cases, but fortunately, I usually put a radial and the femoral arterial line. Radial is usually very nicely palpable, and the femoral we really found difficult to get it. And obviously, we put a radial and femoral both just to identify either it can be a coarctoplasty in a cath lab or it can a surgical repair in the OT. We need to check whether the surgeon has done the job nicely, the gradient has come down, or the cardiologist has done the job nicely. Superficial temporal artery, honestly, I don't have much experience.
Superficial temporal artery is not a usual target. I mean, it's rarely ever a target for arterial cannulation for me.
Exactly.
As you said, correctly said, Dr. Subhendu, in coarctation of aorta, you have very good proximal pulses. I mean, patient has proximal hypertension. And then now we have ultrasound access, and an arterial cannulation should not be challenging. If you fail distally with the radial artery, put it a little proximal and you'll see the radial artery there. You need not miss the radial artery now that we have ultrasound. It's not blind anymore.
Absolutely.
These are the questions from the audience. We have one more question from Dr. Muthu Kumar, and this is to Dr. Rohini. What is the way of weaning off IABP?
For that, we'll have to look at clinical parameters as well. So once the tissue acidosis is improving, lactates are settling down, you're able to reduce the inotropic support, or you have a visible improvement in contractility over the echo. That is when you will start weaning the IABP. Remember, you shouldn't be in a hurry to wean IABP because these are very critically ill patients and you put in IABP. So once everything is stabilized, say for 24 hours, the past 24 hours, things are going smooth. At that time, you will start of thinking of weaning IABP. And there's a method to do it. If I can share my slide at this point, can I do that?
Yeah, your sharing options are
slide. There was one slide in which I portrayed the screen of the IABP. In this, if we can see next to the triggers, there is something known as IAB frequency. That is the ratio of 1:1, 1:2, and 1:3. Here on the monitor, we see that the IABP is being inflated in a 1:1 ratio. That is, every beat is being supplemented by the IABP. So, if one is
your computer screen has not been shared.
Not being shared?
No, we don't see it. I don't see it.
Oh, let me try it again. How about now, sir?
No. See, you are not sharing it.
No, I did share it. Maybe there's a technical issue. Anyway, even without it, I will.
No.
I will talk about it. Beside the trigger, we do have. Beside the trigger option, we do have something known as a IAB 1:1 IABP frequency ratio. That is 1:1, 1:2, and 1:3. So instead of augmenting every beat, we can reduce it to 1:2 augmentation and see for a couple of hours if the patient tolerates it, and then reduce it to 1:3. That is, every third beat is assisted by IABP. So this is one method of weaning, and the other thing is there is something known as augmentation. There is minimum augmentation and there's a maximum augmentation. The amount of helium which fills the balloon. So even with that, we can start weaning IABP. And one more thing to keep in mind is during weaning process of IABP, if you're putting IABP on standby and seeing if the patient's hemodynamics are well maintained just with inotropes and pharmacotherapy. So that time we have to be careful that we do not put the IABP on standby mode for more than 30 minutes. It's not recommended to keep the IABP on standby for more than 30 minutes. So once with weaning, say 1:3 frequency, or the augmentation is also completely reduced, the patient is tolerating this, IABP can be put on standby mode and it can be removed.
So the point is the IABP, the consideration to wean IABP is made once the cardiac function has recovered. So first marker for the thought process is cardiac function should recover. So all the markers of cardiac output, cardiac output itself is directly measured, and other indirect measures of cardiac output like renal function and all are showing good values. Then you think of weaning from IABP, and nobody in practice we don't simply switch it off. So either the augmentation for every heartbeat is stopped and changed to once in every 2 heartbeats or once in every 3 heartbeats is augmented, or as Dr. Rohini said, another method is to reduce the amount of inflation in the helium balloon. So one point which I want to emphasize here is how to read an arterial trace when an IABP is IABP has been inserted. Is my screen seen?
Yes, sir, it is seen.
So on the third panel is the arterial trace, which has been augmented by an IABP. So you see the value as 106/64. This is not 106 is not the systolic pressure. 106 is the augmented diastolic pressure, and systolic pressure is seen here. This is somewhere around 90. Is my cross marker seen?
Yes, sir, it is seen.
Yeah. So when you read the pressure tracing, the arterial pressure tracing, you have to look at the screen of the IABP. So 118 is the augmented pressure, which is shown here, and the systolic pressure is 90. So when the augmentation is proper, the unaugmented systolic pressure is much less than the augmented diastolic pressure. So the pressure you see as systolic pressure is actually the augmented diastolic pressure. I just wanted to mention that whether this has been understood by the audience or not. I'm not very sure.
No, I don't think, I did not make a comparison of the arterial trace with the IABP screen.
This is an extremely important point.
Okay, and I do want to direct a question to Dr. Parimala. Audience have not asked a question, so may I take the liberty to ask you one small question?
Yes.
So when do you consider inserting a spinal drain for patients coming for TBAR? What are your considerations? Whether you would insert a CSF drain, whether you will not insert a CSF drain?
Very few patients we have inserted, usually in consultation with surgeons when there is an extensive aneurysm. So basically, when we know that there is going to be a prolonged procedure, cross clamp is for a prolonged procedure, and left subclavian is compromised. And one patient recently we had actually delayed spinal cord injury, and still the surgeon was not willing to put a spinal drain. So it depends on the pathology and also the team. So when we put that drain, we have to remove maximum 10 or 20 ml per hour if the CSF pressure or CVP goes more than 10. So we have to keep that CSF pressure below 10, or if you are monitoring CVP, it should be less than 10, so that we maximize the spinal cord perfusion. So it's based on the anatomy. When there is extensive thoracoabdominal aneurysm involving, especially that watershed area T4 to T8 is involved, there is a risk. But most of our patients have done well without a spinal drain. But few patients still we have seen. One patient, in fact, had complete paraplegia. Some of them have paraparesis and they improve gradually. So the pre-operatively, electively, if surgeons are willing, then we have put epidural catheter and drained CSF. And post-operatively also, if patient shows delayed spinal cord injury, we can do so.
Dr. Subhendu, you want to add, Dr. Rohini, you want to add anything onto your lecture? Which you have,
Nothing, sir. Probably, I mean, a little more extensive because IVP is a little too extensive to be shortened into 10-15 minutes. So maybe next session, if we have some more time, I would like to add on to the different waves, some troubleshooting on IVP. What is how to interpret different kinds of waveforms? What is early inflation, late deflation? All of these issues. Probably we can have another session on that. Nothing today, sir. Nothing today.
one thing I do want to add on regarding this spinal cord protection for thoracoabdominal aneurysms, whether endovascular or open repair. One disadvantage of endovascular procedure is that you sacrifice all the segmental arteries. There is no way you can reimplant. I mean, unlike surgery where you can reimplant. So the concept we rely on is that the spinal cord blood supply is from a collateral network from 4 different zones. The collaterals arise from subclavian, from the thoracic aorta, from the abdominal aorta, and the iliacs. So if more than 2 zones are going to be covered, we then put a CSF drain, and we believe that the spinal cord is at risk, and go proactive on protecting the spinal cord, like inserting a CSF drain, maintaining a high mean arterial pressure. So I thought I'll just add on to that.
Thank you, sir.
That's all from my side.
Thank you, sir. There is no question, we can conclude the session.
So there are no more questions.
Then thank you, Dr. Sunil, for the wonderful coordination between these 3 speakers. See, as all the 4 faculty have touched our heart, our aorta, even the peripheral artery. So we are very happy about that. Even though our cardiovascular system is not having any defect, you have touched all the areas, cardiovascular tree, without any defect. So I'm really very happy, and really it is a dream world for us that so many things are happening. It is an eye opener, and the majority of the people are not asking question for the simple reason they are aware only what is happening now. Many might not have seen this IABP endovascular procedures, and Dr. Subandhu, as usually, has kept it very simple. So that's what we wanted to have, because we want to educate the postgraduate youngsters. And all the 4 faculty have done very well. And even the chairperson was ready with the slides to show that is his expertise. And the Jayadeva Institute of Cardiology was represented by 2 speakers, madam as well as her postgraduate. So we are really very happy. And now I request Dr. David, our treasurer, to propose formal vote of thanks.
Yes, sir. Good evening to all. On behalf of ISA Pudukkottai, first of all, I would like to thank our academic chairman, Dr. ALM, sir, for successfully conducting the 39th webinar. Thank you very much, sir. And special thanks to today's chairperson, Dr. Sunil, sir, Professor, Department of Anesthesia, Shri Chitratrinal Institute of Medical Sciences, Trivandrum, for sharing his experiences. Thank you very much, sir. And I would like to thank today's speakers, Dr. Parimala Prasanna ma'am, Professor of Anesthesiology, Sri Jayadeva Institute of Cardiovascular Sciences and Research, Bangalore, and Dr. Subendra Sarkar, Head Cardiac Anesthesia, Desun Hospital and Heart Institute, Kolkata, and Dr. Rohit, Mayor, Cardiac Anesthesiologist, Apollo Tiruchirappalli, for making a wonderful academic session. Thank you very much. And also thank other faculties and postgraduate and ecologics for technical support. Thank you all.
Thank you.
Thank you.
Thank you, sir.
Thank you all for the wonderful opportunity.
Right. Thank you. A1 Logics can end the meeting.
Thank you all, sir.
Thank you.
Thank you. All have done wonderfully well. We are very happy. So we have to maintain the same tempo. That's the problem.
Yes, sir.
Thank you. Then A1 Logics, please